to introduce our next speaker, Dr. Luke Martin from Emory University. He is the professor of radiology, and he's going to give us a talk on endovascular treatments for pulmonary embolus.
Thank you very much. Most of the things we're asked to talk about at meetings like this are subjects that there is not very much data on, or level 1 data. And the pulmonary embolism doesn't fall into that category. There's a tremendous amount of very good data on pulmonary embolism, and I'm going to go over some of that with you today. I don't have any conflicts which pertain to this talk, and I will be discussing non-approved use of devices. P is a serious business, as you know. It's got a very high incidence. The mortality on it is quite high. We have, in just my own personal experience, one of my secretary's husbands died after a hip replacement of a pulmonary embolism in the hospital. I went to the post-mortem examination on him. There didn't look like there could be a bit of oxygen that could ever get to the lungs. The pulmonary arteries were just packed solid with thrombus. And then just recently, within the last 6 months, one of our technologists, a 35-year-old young lady, died of a pulmonary embolism in the emergency room. They tried to resuscitate her and couldn't resuscitate her. So it happens to all of us. We see it so commonly. It's something that we deserve to know a little bit more about. I'm going to just, as a start, I'm just going to present this patient that I saw within the last year at one of our mid-city hospitals. A 34-year-old male admitted to the inner-city hospital with acute chest pain, hypoxia, and hypotension, and you can see this thrombus here in the pulmonary arteries. This is contrast for those of you that aren't used to looking at CT angiograms. This is contrast in parts of the heart and the vascular system, but this is thrombus in these main pulmonary arteries, and the thrombus acts like a cork, and the blood just can't get by. So I'm going to show you how we treated this patient, and then we'll talk about the different ways that we could have treated him. Received a call on the patient at 6:30 at night, and we ordered TPA, a 20 milligram bolus and a 30 milligram 2-hour drip to be started immediately. Nothing is immediate, as you know, working in hospitals. Took about an hour to get started and to receive the TPA, and then they gave the bolus and started the drip, and about 2 hours later the patient actually reached the IR suite. And then it took us about 2 hours to get him on the table, get him prepared, do the procedure, and get him off the table. And so after that, after the TPA, the patient was placed on heparin. And the patient did quite well. This is what we did initially. We did a vena cavagram. You can see that we're going from the internal jugular vein approach, and did a vena cavagram. There, you can see there's thrombus down in the vena cava, placed a filter. Went ahead and did a pulmonary arteriogram, and I'm going to talk about scrubbing the pulmonary arteries with catheters. Now, this is just a 5 French omniflush catheter. It's not the ideal catheter to use, but we came down and went in here, and you can see the catheters moving up and down in the pulmonary artery. And what it's trying to do is break up that thrombus and let it embolize peripherally. And so we've done that. We think that we've increased the perfusion a little bit on this, that you could argue that I've got rose-colored glasses. There are better catheters to use than this 5 French catheter, and these are pulmonary artery catheters, and they're 6 and 7 French. Here is a Van Almen catheter, and this is a Montefiore catheter, and this is a Grolman catheter, and these are stiffer and much better to use. In the case that the catheter that I had to use, I had to put a stiff wire into it to try to give it more body. Went on the other side into the right pulmonary artery and got over here and did the same thing, and we think that we improved the circulation a little bit. The patient did pretty well, was placed on level 2 heparin, had no heparin until the TPA was in, was doing well on the 3rd post-op day, and then, of course, was discharged in fairly good condition. The endovascular treatment of pulmonary embolism really includes anticoagulation, thrombolysis, and the thrombolysis can either be given peripherally, as we did in this case, or it can be given through a catheter directed into the clot, and it can be done with mechanical assistance. And one of the ways of assisting mechanically is breaking up the clot the way that we did in that case with the pulmonary artery catheter that we were running around. Or you can treat with mechanical assistance alone, or you can do a surgical thrombectomy. And of course, the surgical thrombectomy isn't actually an endovascular therapy, but it should also be considered. And the way that you make this choice is by risk stratification in the patient, the choice between these three main endovascular treatments. And there's a tremendous amount of level 1 data on all of this. If we take a look in a PubMed search, we can see that there are over 6,000 articles on acute pulmonary embolism, and mechanical thrombectomy has 600 articles. And if we took a look at acute PE in randomized controlled trials, there are over 1,000 of these randomized controlled trials. So there's a tremendous amount of this level 1 data. If we take a look at massive pulmonary embolism, which we were talking about in the patient that I just presented, and a randomized controlled trial, there are 53 of them. We're lucky to have 1 or 2 in other areas. Now, if we look at mechanical thrombectomy, mechanical thrombectomy with that assistance, and massive pulmonary artery embolism, and randomized controlled trial, there aren't any. And so that's a point of contention and something that we may have to discuss. If we take a look at the level 1 data, the thing that's the most striking is that there's no survival benefit to treating a submassive pulmonary embolism with thrombolytic rather than heparin infusion. The patient, there's no survival benefit. Now, so we have to distinguish between a massive and a pulmonary embolism that's not massive. So the symptoms of a massive pulmonary hypertension include significant and persistent hypotension, hypoxia, hypoxemia, and shock. And the signs, the clot burden obstructs the flow of the central pulmonary artery branches, as I mentioned in that other case, and it acts like a cork, preventing the blood from getting into the peripheral pulmonary arteries. Develops, the right heart starts to fail and enlarge. There are large perfusion defects on the computed tomographic angiogram or nuclear scan in the lungs. There's free-floating right ventricular thrombus may be seen. The right heart pressures can be so high that they may reopen the foramen ovale. Usually the left ventricle is much larger than the right, but in this case the right ventricle becomes as large or larger than the left, and the interventricular septum becomes bowed toward the left. And so if we take a look at this, here's another case of a massive pulmonary embolism. You can see this horrendous clot burden that's occurring. You can see this, on this case, you can see this bowing of the interventricular septum toward the small left ventricle. Here's that large right ventricle I was talking about, and of course in an echo study, bowing of the interventricular septum and the right ventricle becoming larger than the left. I don't know very much about the EKG findings, but I've been told anyway that the cardiologists are very comfortable in taking a look at right heart strain with EKG. So there's no evidence that thrombolytic infusion through a catheter placed directly into the clot confers a greater benefit than a peripheral venous injection. So why do it? I mean, why take the time to go to the cath lab and stick a catheter into the pulmonary artery and infuse a thrombolytic agent when you can just go ahead and give it in a peripheral IV? It's much more costly and time consuming to do it by the catheter method. And level 1 data also tells us that IVC filters, as Dr. Link just said, they decrease recurrent hypertension, pulmonary embolism, but they cause an increase in recurrent DVT, and they do not improve survival. So there's no level 1 data that suggests that IVC filters are of benefit in these patients. The use of vena cava filters should be reserved for patients with contraindications to anticoagulation therapy, according to some of the guidelines that we have. And this is from a lawyer site, and you can see that the IVC filter complications are very serious and can be life-threatening. And they're talking about, they've taken a look at the MAUD database with the FDA and see how many things are being reported to them and the complications. And they're trying to get these patients to come on in and make a complaint against you if they've survived, or their families to file suit. And the caveat really is that if you're going to put a filter in, don't forget to remove them when the treatment is completed, if at all possible. Now, there's quite a bit of difference in removable IVC filters. And these are two that sort of fall at different ends of the spectrum. And the Optese filters, it's very good at filtering the thrombus from the cava, preventing it from getting up to the lungs. It does have a high incidence of caval occlusions, but it has to be, if it's going to be retrieved, it has to be retrieved very early. And the company wants you to go back in and retrieve it in 23 days, whereas filters like the Select IVC filter made by Cook has been retrieved after 300 days, and it has to do a lot with the construction of the filter. Now, this one is going to have a lot more trouble with legs perforating the IVC and going into the aorta or the kidney or other places that you don't want them, and legs fracturing. This one, the sides of this filter are incorporated very quickly in the endothelium of the vena cava, and you just can't get it out. And it's a mistake to try to get it out after the 23 days or 30 days window that you have. Now, why would we want to do lysis with mechanical assistance? And it's to increase the clot surface of the lytic agent and to decrease the central clot burden. And who should we do it on, then? Should we do it on everybody? Currently, there's no evidence-based guidelines that identify those patients who should be treated more aggressively with endovascular therapy. The American College of Chest Physician guidelines recommend against using mechanical approaches in most patients with PE, and they say that it should be used very selectively in highly compromised patients who are unable to receive thrombolytic therapy and whose critical status does not allow sufficient time to infuse a thrombolytic agent. That doesn't make a whole lot, the second statement doesn't make a whole lot of sense, because if to start an IV and infuse a thrombolytic it takes much less time than it does to get in there and to do the catheterization. So the rationale for mechanical assistance is based on rapid relief of that central obstruction, break up that clot, and put it peripherally into the more distal vessels. There's 4 times the room in the peripheral vessels than there is centrally. So if you can break up the clot can be treated as it moves peripherally, and it's a much benefit. And it increases the surface area of the clot exposed to the lytic agent. So you're breaking it up and fragmenting it, and so instead of just acting on the external part of that clot. So how do you do it? Well, you can do it with a variety of different methods. We talk about pulse spray of the thrombolytic agent, mechanical disruption of the clot with a variety of different devices, or we can remove the clot mechanically with a variety of devices here, and we'll talk about some of those. The EKOS catheter is a catheter that has a central transducer that has an ultrasonic beam, a high-frequency ultrasound beam in there, and supposedly that goes and breaks up the thrombus. And then there are infusion ports along the catheter that inject the thrombolytic agent. Pulse spray thrombolysis is shooting the thrombolytic out in a sort of a very fine, forceful spray, sort of like using a power hose on trying to disrupt that clot. It disrupts the clot mechanically, and then it also increases the surface area of the clot that you're treating. These are other different devices. It looks like an egg beater. This is a Trartola device. You put it inside the thrombus and beat it up. A cleaner device, same thing. The angiojet rheolytic thrombectomy system supposedly sprays out the thrombolytic, and then it circulates it and fragments the clot and brings it back. The angiojet therapy, unfortunately, it's related to a high complication rate. The Quo and Bovini, two of the people that you'll see referred to in the reference list, talk about Quo did a meta-analysis of mechanical assisted thrombolytics, and only about something like 8% of them had a complication. 70% of the complications that occurred related to the angiojet. So you can see that it's a very dangerous thing to use. Okay, here's my algorithm for treating it, and then I see I'm running over time, so I'm going to have to sort of go through these fairly fast. But in a hemodynamically stable patient on room air without vasopressors, you confirm the diagnosis, exclude free-floating thrombus either by a non-invasive study or a vena cavagram, place a filter if there's vena cava thrombus that might, and treat with anticoagulation. Hemodynamically unstable but controlled, confirm the diagnosis of the massive PE, exclude the free-floating thrombus, treat with IV, TPA, and a 2-hour drip, followed by heparin and Coumadin. Hemodynamically unstable and can't be controlled with no contraindication to thrombolytic therapy, determine the use for the IVC filter, bolus and drip with high-dose TPA, macerate the clot the best you can with any means that you have. The method depends on how high the risk of the patient and how effective the maceration is. If you're not making any progress, place a pacemaker, give atropine, and use the angiojet. High-risk patients with absolute contraindications to thrombolytic therapy and patients that have been turned down by the cardiothoracic surgeon, heparinize if possible, place an IVC filter, macerate the clot by any method necessary. The benefit in these patients is very low, but it's worthwhile trying. Thank you very much.
Thank you, Dr. Martin. For those of you who do have questions, please write them down and we'll certainly discuss them.
Data on, or level 1 data, and the pulmonary embolism doesn't fall into that category. There's a tremendous amount of very good data on pulmonary embolism, and I'm going to go over some of that with you today. I don't have any conflicts which pertain to this talk, and I will be discussing non-approved use of devices. PE is a serious business, as you know. It's got a very high incidence. The mortality on it is quite high. We have, in just my own personal experience, one of my secretary's husbands died after a hip replacement.
To introduce our next speaker, Dr. Luke Martin from Emory University. He is the professor of radiology, and he's going to give us a talk on endovascular treatments for pulmonary embolus.
Thank you very much. Most of the things we're asked to talk about at meetings like this are subjects that is not very much started. I'm just going to present this patient that I saw within the last year at one of our mid-city hospitals. A 34-year-old male admitted to the inner-city hospital with acute chest pain, hypoxia, and hypotension, and you can see this thrombus here in the pulmonary arteries. This is contrast for those of you that aren't used to looking at CT angiograms. This is contrast in parts of the heart and the vascular system, but this is thrombus in these main pulmonary arteries, and the thrombus acts like a cork, and the blood just can't get by. So I'm going to show you how we treated this patient, and then we'll talk about the different ways that we could have treated him. him. Received a call on the patient at 6:30 at night, and we ordered TPA, a 20 milligram bolus and a 30 milligram 2-hour drip to be started immediately. Nothing is immediate, as you know, working in hospitals. Took about an hour to get started and to receive the TPA, and then they gave the bolus and started the drip, and about 2 hours later the patient actually reached the IR suite. And then it took us about 2 hours to get him on the table, get him prepared, do the procedure, and get him off the table. And so after that, after the TPA, the patient was placed on heparin. And of a pulmonary embolism in the hospital, I went to the post-mortem examination on him. It didn't look like there could be a bit of oxygen that could ever get to the lungs. The pulmonary arteries were just packed solid with thrombus. And then just recently, within the last 6 months, one of our technologists, a 35-year-old young lady, died of a pulmonary embolism in the emergency room. They tried to resuscitate her and couldn't resuscitate her. So it happens to all of us. We see it so commonly. It's something that we deserve to know a little bit more about. I'm going to just, as a